Hey kids, welcome to Reading with Lamb. Today we're going to be covering an article from the New England Journal of Medicine. This is a correspondence from the Zhang group with regards to coagulopathy and antiphospholipid antibodies in patients with COVID-19. So what they're trying to do is to describe and bring awareness to a patient with COVID-19 and clinical findings of coagulopathy, which is problems and issues with the ability to form blood clots, antiphospholipid antibodies, which we'll discuss in greater detail later on, and multiple infarcts. Infarcts being the end tissue damage due to lack of oxygenation. This is the paper that we're going to be evaluating, and it comes from Wuhan, China. We will be looking at 3 patients who have been diagnosed with SARS-CoV-2, which is the virus implicated in COVID-19. Now, the diagnosis was done through RT-PCR, which is reverse transcriptase polymerase chain reaction. And if we scroll down to table 1, we have the demographics for our patients. Age-wise, they're pretty similar at 69, 65, and 70. We have 2 males and 1 female. As far as their medical history is concerned, all 3 have high blood pressure. Patients 1 and 2 has diabetes. Patients 1 and 3 has a history of a stroke, although we're not certain if it's ischemic in nature or hemorrhagic in nature, though based on the probabilities, it's most likely ischemic, and because later on we'll find that all 3 of these patients have thrombotic events, which is blood clotting events, I'm going to lean towards ischemic stroke. Interestingly, patient 2 has no history of thrombus formations, right? And so when we look at the symptoms at disease onset, we notice that the symptoms are pretty nonspecific, right? You have fever, coughing, dyspnea, which is difficulty breathing, diarrhea, and headaches. Upon imaging, we find that patients 1 and 2 has this ground glass opacity, and all 3 have bilateral pulmonary infiltrates. This is an article on the role of imaging in COVID-19. It comes to us from European Radiology. And the main point that they make is that while viral nucleic acid detection is the gold standard of diagnosis for COVID-19, it leads to a lot of false negatives. And so they give you an introduction on COVID-19. It causes a pneumonia, and the pneumonia is more likely to affect persons with advanced age or other comorbidities, which our patients have. Right? We have the high blood pressure, we have the diabetes, the history of a stroke, among other things. Now, the pneumonia can progress to a fatal respiratory disease. One such is the ARDS, acute respiratory distress syndrome. So our 2 modalities for imaging are going to be the chest x-ray or the CT scan. And with the chest x-ray, the issue is that they're relatively insensitive to detecting COVID-19 in the early stage. But if you wait long enough and the patient progresses a certain point in their disease state, you're going to find that there are going to be multiple patchy opacities, and eventually you might see the whited out lung in severe cases. As far as the CT scan is concerned, they're recommended because they are very sensitive to detecting early disease. And what you might find, right, is multiple, peripheral, bilateral, ground glass opacities. So here in table 2, they've highlighted the general features that you would find on CT imaging. And in table 3, they combine the frequency of these findings with certain stages of disease. So they stratify it into 4 categories, where you have early, in which you see ground glass appearances, then you see consolidation in the advanced stage, in the severe stage you see the diffuse consolidation, and then you have the dissipation stage in which you find resolution. Here we have figure 2A, which is a chest x-ray of a 61-year-old male with diffuse radial opacities on both sides of the lungs. And in figure 2B, we have a 33-year-old female. This is a CT scan showing bilateral ground glass appearance. And in figure 2C, we have a 71-year-old male. This is a CT scan showing on the right side consolidation, and on the left side more consolidation with diffuse amounts of ground glass appearances. Figure 4 is perhaps the most important figure in that it shows you the CT scans through early stage all the way to dissipation stage. So once more in the early stage, what we're going to see is the ground glass appearance. In the advanced stage, we're going to begin to see consolidation. And in the severe stage, we have diffuse consolidation and what is also called whited out lungs. And then in the dissipation stage, you see the resolution of all that. This is a summary slide. And so once more, RT-PCR, which is the nucleic acid detection, is the gold standard. But the issue is it causes a lot of false negatives. Now, what we want to do is we want to use imaging as an adjunct to the diagnosis of COVID-19. So with CT imaging, what you're going to find is ground glass opacities and consolidation. Interestingly, CT scans have a high sensitivity compared to RT-PCR for detecting disease. So it's 98% versus 71%, and there's a statistical difference as shown by Fang in 2020. And so with high sensitivity, what that means is if the test shows that you are positive for disease, you have 98% likely that you have the disease, as opposed to the RT-PCR, which is 71%. Now, before we get back to the lab findings for our 3 patients, let's go over the antiphospholipid syndrome. This is a autoimmune disorder in which it manifests in thrombosis in association with certain antibodies, and these antibodies are the lupus anticoagulant, the anticardiolipin, and the anti-beta 2 glycoprotein 1. Now, the thrombus formation, which is the blood clots, they form pretty much everywhere, right? The arterial, the venous structures, the microvascular structure, and it can affect relatively young individuals. Well, you might ask, well, what's relatively young? There was a Europhospholipid project study where they evaluated 1,000 individuals, and greater than 70% of those individuals who had a stroke or a venous thromboembolic event had a median age of 40 years old. That's pretty young. So what is the conventional treatment for APS? It's going to be vitamin K antagonist. Some people have suggested the use of factor 10A inhibitors. And the other thing of consideration is that APS can be refractory to these types of treatments. And so you might use these anticoagulants and find that it doesn't quite work. Now, APS and disseminated intravascular coagulation, which is DIC, share similar features, such that DIC features are not rare in catastrophic APS, catastrophic APS being the severe variant of APS. Now, in APS, you're going to find thrombocytopenia, which is a decreased platelet count. You're also going to find antiphospholipid antibodies, which is not surprising. In DIC, you're going to find thrombocytopenia, prolonged PT, decreased fibrinogen, which is the precursor to fibrin in the coagulation cascade and is being utilized, increased fibrin degradation products, and increased D-dimer, which are both indicative of a thrombotic event. And on the right side, we have the International Scientific Subcommittee for the diagnosis of DIC. At this point in time, we're going to scroll down to the lab findings, where we see that patient 1 has an elevated white cell count, elevated neutrophil count. Patients 1 and 2 has thrombocytopenia. Our PT and APTT are elevated for all 3 patients. Our fibrinogen levels are mildly elevated for patients 1 and 2. It's very marginal. And patient 3 is definitely elevated. Now we would expect in the case of a DIC that this would be lower, but there are other factors that can cause the fibrinogen level to actually increase. With regards to fibrin degradation products, we see that patient 1 is elevated. And for D-dimer, all 3 patients has elevation of D-dimer. Now, all 3 patients also have anticoagulopathy and anti-beta-2 glycoprotein 1. It is at this point that I want to bring your attention to the Sydney Consensus Statement on the classification of APS, in which you need at least one of the clinical criteria as listed below and one of the laboratory criteria. So you will see that we do have evidence for vascular thrombosis clinically, and in terms of the laboratory criteria, although we have the anticoagulopathy and the anti-beta-2 glycoprotein 1, please notice that you need 2 or more occasions 12 weeks apart in order to actually make the diagnosis. So in this case, I don't believe we have that. Returning to our patients, we notice that they have multiple cerebral infarcts, and patient 1 also has ischemia in the lower limbs bilaterally and ischemia in the left hand. So in conclusion, we have 3 patients diagnosed with COVID-19 via RT-PCR, 2 of whom have actually shown ground glass opacity in their CT scans. They have multiple ischemic events in the brain. Patient 1 had additional multiple ischemic events in the limbs, and so there is suspicion for APS. Now, the authors, Zhang et al., do state that these antibodies can also arise transiently in patients with critical illness and various infections. However, the presence of these antibodies rarely lead to thrombotic events that are difficult to differentiate from other causes. So what I take out of this is that we want to bring awareness to the observation that we have patients with COVID-19 who also presents with possibility of APS, and that if we begin to see more of this, then perhaps there is some type of association. These are the citations to the articles we have read today. And of course, thank you for reading along.